Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome back to Year in Review. As today we focus on new data sets and developments in the novel treatment approaches for non-Hodgkin lymphoma. We have a great faculty today, Dr. Matasar from the Rutgers Cancer Institute and the Rutgers Robert Wood Johnson Medical School in New Brunswick, New Jersey, and Dr. Sonali Smith from the University of Chicago in Chicago, Illinois. So as we do in all of our Year in Review programs, I met separately with each of the faculty to record a presentation. We're going to go through a lot of the slides from those and some of the topics. We also today, as in all of our webinars, will be discussing the use of unapproved treatments and regimens. So check out the available package inserts for more. So these are the two title slides from the presentations. They're both great presentations. They're in the chat room. Also, if you want to look at it after the fact, when we send out this webinar, along with that, it'll be these two great presentations. And there you go through all the data from these trials and discussion of it. Tonight, we're going to sort of take it to here are the papers that were discussed, quite a few papers. We're not going to talk about all these, but some of these. But today, we're not going to focus so much on the slides and the data, more like what it means for clinical practice, but also for future clinical research and ongoing clinical trials. So first, we're going to start out in a second talking about papers over the last year on diffuse large B-cell that Matt presented. Then we'll talk about papers on follicular lymphoma, mantle cell lymphoma that Sonali presented. But before we get into that, just to take a deep breath and sort of palate cleanser or whatever you want to call it, warm up, I'm noticing that Matt has a long-standing, and both our faculty really, Matt has a lot of publications on lymphoma survivorship, which I noticed, and there are two of them that I recommend for you to check out in the slide set. This one in particular from JCO Oncology Practice I really like. They interviewed, when we think about survivors, I think you think about short-term treatment, obviously, for example, diffuse large B-cell, R-CHOP, Hodgkin lymphoma as well. Short-term treatment followed by cure in a lot of patients, and then long-term issues. And this second paper, I interviewed a bunch of survivors themselves as well as providers, and came up with three important themes. One, of course, the anxiety that people have about potential recurrence. Also, I thought really interesting the issue of primary care. I mean, these people, hopefully are cured. We have issues of what kind of cancer screening they're going to have, long-term effects, et cetera. And then all the supportive services that people need, including financial. So I know, a lot of cancer centers, including both of yours, have actually survivorship clinics and specialization with multidisciplinary people involved. In the community, usually you don't see very much of that. So I thought I'd just kind of get your brief thoughts on what your survivorship programs look like. We are the kind of people, the kind of services provided, and any issues. We have it's almost July 1st, time for the new fellows when they come in July 1st, and they see a patient who's getting followed up for who's got R-CHOP and NED now. I'm curious how your centers deal with these people and what kind of clinics you have. Matt, how about at Rutgers?
At Rutgers, our survivorship program sort of takes two shapes. We have the traditional physician-led model for people who are at high risk for late effects because they've received complex treatment associated with late cardiovascular toxicities or second primary malignancies. And then there's sort of the APN-led model where our wonderful APP partners take care of patients who are completed with treatment, don't need surveillance imaging anymore, but are in that period where we want to keep track of them before discharging them to routine follow-up in the community. And I think this two-tiered model where you have APPs that can develop longitudinal relationships with patients, but keep them in the fold at the cancer center. And then that second tier, which is really for the patients who are at the greatest need for complex multidisciplinary survivorship care, is a nice model. But I'd love to hear what's going on in Chicago with you, Sonali.
Yeah,
Tony?
thanks so much. Yeah, so for survivorship, maybe just a couple of points. One is that, through the Lymphoma Research Foundation, this has been a big part of their mission. And there's actually a survivorship working group led by Lindsay Morton. And just in 2025, we published a surveillance of the literature about survivorship and lymphoma with Brian Valcarel as the first author. And, our main finding, really reflects what you found, Matt, but, in specific, the details are that there's really no one survivorship plan that is the best. They're all different. And we are now in a complicated era where we not only have people who are cured of their disease and in a traditional survivorship mode, but also people who have chronic states of disease and sometimes on ongoing chronic therapies. And so the survivorship needs are similar but different, and so I think it really needs to be tailored. At University of Chicago, we have something called holistic oncology, where there are a number of different services that are offered, including acupuncture and psychological care. But I think the part that I'm really proud of, regarding the first theme that you had pointed out, Neil, is that we have a psycho-oncology service that really focuses on the sphere of recurrence, as I find that's a really common issue.
So understandable. And of course, I think every time a patient has any symptom, the first thing you're going to think about is recurrence. So it's a real uphill battle there. I was thinking a lot about this issue of primary care too, like who determines, I was thinking, wouldn't it be a shame if somebody was cured of Hodgkin or diffuse large B cell, developed colon cancer without getting appropriate screening. Now we don't even need colonoscopy. What a shame that would be. I just wonder how often people sort of fall through the cracks. But I just want to bring that up. We rarely get into it. We usually just jump into treatment, which we're about to do. But I just wanted to bring that up. And hopefully now with CAR-T and other new therapies, we'll see even more survivors. All right, let's talk about some of the papers that came out this year. And also keep in mind, the EHA meeting just finished, I think, today. They just released their slides in the last few minutes. The faculty and I were looking at some of the slides because they just got published. We're going to talk a little bit about what happened at EHA and at ASCO as well. But Matt, you talked about, of course, we've been talking about the Polarix study for quite a while. You talked about the 5-year data that was recently presented. Particularly the survival data. But also you brought up this paper that was just presented at the ASCO meeting, the Front-Mind study. A second paper, phase 3 trial that's positive in upfront treatment of diffuse large B-cell, tafasitamab R-CHOP versus R-CHOP. Matt, can you summarize a little bit about what your thoughts are, what the key findings were from your point of view? Now you have both of these studies, Polarix. Of course, we've had all the debate about cell of origin with Polarix, and now we have Front-Mind to think about. How does a Front-Mind study tie into your thinking about first-line therapy at this point, Matt?
It's a really good question. I think that a lot of us are trying to digest these data newly presented and co-published in the Lancet concurrently. My take on it is this. First, remember that this is a study that treated a higher risk patient population than we did in Polarix. So this is for IPI 3+, not IPI 2+. And unlike Polarix, where it was sort of a switcheroo, you're switching vincristine for polatuzumab, generating two regimens with largely identical toxicities. Here, you're adding on two additional drugs. You're adding tafasitamab and lenalidomide on top of the intact R-CHOP backbone. What do you get? What's the juice for the squeeze? You get a PFS benefit of a similar magnitude quantitatively that we got by switching out Pola for vincristine without a demonstrable or statistically significant overall survival benefit. With Polarix, we are all very happy making a switch for a PFS without OS benefit because of identical toxicities. I'm not sure that's going to be true with Front-Mind. I think we need to think about this pretty carefully because we're adding drugs that are going to drastically change the treatment schedule, with tafasitamab having a notoriously cumbersome treatment program with weekly infusions, combined with the additional toxicity of lenalidomide in first-line therapy, which does add toxicity to the program, setting aside issues of financial toxicity as well. So I think that we're going to have to digest these data more fully before I and perhaps others are comfortable in adopting it as a new standard.
So, Cindy, I'm curious about your thoughts. It sounds like Matt's not necessarily super excited to jump right in there, and he explained a good rationale for that. What are your thoughts? And also, this issue that's been out there for a while with Polarix, which is cell of origin. Do patients with GCB tumors respond to this strategy? Any comments, Sony?
Yeah, I think Matt, made some really good points. I think the way this study could really change practice is in the germinal center diffuse large B-cell lymphoma, because there wasn't quite the the difference based on at least that approach. So at least for right now, I think it is a standard that could be adopted. But the logistic barriers of weekly TAFA, I think, are significant. And we also know that there are a lot of bispecifics in the frontline setting that may, make this study maybe less appealing if some of the other studies show a bigger magnitude of difference, in efficacy without the safety issues. I think overall this is, there was more toxicity. I have stopped using the word acceptable toxicity. I would just say it's manageable toxicity. But I think that, this is a reasonable regimen for germinal center diffuse large B-cell lymphoma.
So, Matt, you also talked about a really interesting study called the SMART STOP study, where patients start out with a non-chemotherapy upfront approach. Can you talk about the design and what we know about this? It's just a phase 2 study at this point, but to me, really interesting idea.
Yeah, I like this study because it's so provocative. And Jason Weston, who is the lead of this study, is a very innovative and very creative researcher who I have just like the highest respect for. And he in this work is trying to work on early divorce papers with full course anthracycline-based chemotherapy for newly diagnosed large cell lymphoma. The work is that you start with a non-chemotherapy quad, right? Lenalidomide, tafasitamab, rituximab, and acalabrutinib. So 2 monoclonal antibodies, an IMiD, and a BTK inhibitor for 4 cycles. And then do a response assessment, including MRD assays. And for patients who get a CR to that quad, which was quite common, they go on to get 6 more months of that same quad, combined with only 2 cycles of CHOP chemotherapy. Patients who didn't get their CR still get 6 more cycles of the quad, plus all 6 CHOPs. So a lot of treatment, potentially expensive treatment, not easy treatment, but the first time that we've really seen a serious swing at trying to limit the amount of anthracycline exposure needed to deliver efficacious first-line therapy for advanced stage large cell lymphoma.
And Sony, of course, throughout oncology, we're seeing ctDNA, MRD type assays being looked at to de-escalate therapy. And this study also uses ctDNA. I'm not sure whether it was a tumor informed or what kind of ctDNA, but any thoughts about that type of strategy and, looking at that and maybe de-escalating therapy?
Yeah, I mean, as Matt said, this is a very innovative trial. And the first time we heard, not so much the SMART STOP, but the one before that, that was ibrutinib based, I thought it was really quite aggressive to consider treating, people without an anthracycline. However, the MRD data really gives us reassurance that there are a portion of patients who may not need the full anthracycline-based chemotherapy. So I think MRD, whether it's with, phase-seq or, any one of the platforms that are out there, are going to be a part of how we treat diffuse large B-cell lymphoma in the future.
So, Matt, what about BTKIs in non-Hodgkin lymphoma? We'll talk later on. There's a trial with zanubrutinib, obinutuzumab, and FL that is now a strategy being used. I think there's another trial with Acala and diffuse large B-cell up front. But what do we know in general about BTKIs in diffuse large B-cell, Matt? I mean, it gets thrown into this non-chemo quartet, so to speak. But what do we know about how much it might be contributing? And is there a difference in cell of origin and benefit for BTKIs?
So we've known for over a decade now that BTKIs can be active in large cell lymphoma. The early signal showed that is really largely restricted to the activated B-cell subtype when you're using cell of origin construct. We can apply even newer models like the lymphocyte classifier, and you can get even deeper down to talk about MCD subtype and N1 subtype, and really understand the underlying biology of this. But the truth is that BTKs are active in a subset of large cell lymphomas, and that's largely restricted to the ABC type large cell lymphoma. We tried to add a BTK in the form of ibrutinib to R-CHOP in the Phoenix trial some 5 years ago. That was a negative overall study, but showed us that in the subset of patients who were younger and were able to tolerate that combination, that there was a benefit. And that informed the escalated trial, which is a recently completed but not yet reported randomized phase 3 of acalabrutinib plus R-CHOP in ABC large cell lymphoma in patients up to the age of 65. So we're awaiting those data readout, hopefully early 2027, and potentially practice changing if possible.
So, Sony, we just did a program yesterday in bladder cancer where first-line therapy is no longer cisplatin doublets, but an IO checkpoint inhibitor plus ADC, so enfortumab vedotin plus pembrolizumab. Correct me if I'm wrong, and here there's one of the first trials, Sunmo. I kind of feel like there's a little bit of a trend going on in terms of bispecifics and ADCs in lymphomas. We're going to talk about a bunch of trials, including this one, looking at mosunetuzumab and polatuzumab. So any thoughts about this strategy in general, and anything you want to say about this Sunmo study?
Yeah, the Sunmo trial was, I think, a really informative and exciting study, showing that mosunetuzumab and polatuzumab was superior to R-GemOx, which is a traditional strategy in the second line and beyond, but particularly for third line diffuse large B-cell lymphoma. And you can see the curves here. I think in terms of a strategy, what's really exciting is that, chemotherapy, I think, remains an important part of our strategy in diffuse large B-cell lymphoma. But what we're seeing is that most of its bang is going to be in the frontline setting. And when we start to get further out, chemotherapy really does not do very much for our patients, and it certainly adds a lot of toxicity. So having a targeted delivery of a payload, like with polatuzumab vedotin, along with a bispecific antibody is really appealing, and the data really support this. Whether or not we'll replace it in the frontline setting, like we just talked about with SmartStop, I think is probably still a little bit further away, but I think in the relapse refractory setting, immunotherapy, bispecifics, antibody drug conjugates, BTK inhibitors, we have a lot going on.
So in a similar theme, as we again look at ADCs in lymphoma, Matt, anything you want to say about the Polargo study looking at Pola R-GemOx?
So this is sort of one of these three studies that we look at in the second line and beyond large cell, incorporating novel therapies. We just talked about Sunmo. There's the StarGlow trial looking at glofitamab plus GemOx versus R-GemOx. And here we have Polargo, which is Pola plus R-GemOx versus R-GemOx. This was a study that was powered for overall survival and found it with a 40% lower rate of death in patients who have Pola added onto an R-GemOx backbone. We didn't do this as our first combination developing Pola in relapsed large cell because we were worried about neuropathy. And we found that there certainly is neuropathy when you combine Pola and oxaliplatin. But it was largely grade 1 or grade 2 in severity, and half of patients got better and a third of patients had resolution. For me, another provocative part of our findings here is that with all the talk about cell of origin, these data really fly in the face of the perspective that Pola is a cell of origin specific drug, where we found identical benefit for GCB and ABC, adding Pola on top of the R-GemOx backbone, really sort of challenging the idea that that the subset analysis and univariate analysis from the Polarix trial tells the whole story. Maybe it's not so black and white.
So another sort of example of this idea of ADCs coming into diffuse large B cells, the Lotus-5 study of Sonali looking at Lonca-T plus rituximab. Can you talk a little bit about this study and also your experience with Lonca-T? A lot of people have not used this antibody drug conjugate, and particularly in terms of the tolerability issues, but any thoughts about this Lotus-5 study?
Yeah. So loncastuximab-tesirine is the antibody drug conjugate that it's against CD19 with a PBD dimer payload. So really a true, cytotoxic payload. What we know is that, first of all, it's already FDA approved in the relapse refractory setting for large cell lymphoma. And my personal experience has actually been quite good. It's a very easy schedule, once every 3 weeks. And, there's a really nice efficacy. The main challenge, of course, is that there are some unique toxicities, including fluid retention with pleural effusions, lower extremity edema, infections and cytopenias, and then also a photosensitivity as a monotherapy. What this study did for Lotus 5 is it's another one of those, randomized trials where it's lonca-rituximab versus R-GemOx. And honestly, Matt, I think we are done with R-GemOx. I think it has to stop being the control arm for all of our future studies. I think but this one, of course, was started before. And what we've seen so far is the safety run-in, and we've seen a press release about, the study. And at least what we have seen so far is that, there is the expected, edema, pleural effusions that are seen, and the AEs leading to study drug withdrawal is significant, at least in the first part. But the efficacy is also really encouraging. And so, right now the overall response rate that was reported is 80% with a 50% CR rate. And I think what we're really looking for is more longer term durability. The press release did give me pause, I'll just say, for diffuse large B-cell lymphoma, because there were an increase of grade 5 events in people over the age of 75. So I'm really eager to hear more data.
And hopefully maybe we'll see that at the ASH meeting coming up, more data in terms of safety. One of the issues that we know about, I hear a lot about this from investigators, Matt, is photosensitivity. I hear these stories of people who kind of have their hand out the window and they get blistering skin effects. Anything you want to say, anything else you want to say about the Lotus study, but also about your experience with Lonca-T, particularly as it relates to dermatologic issues?
So yeah, photosensitivity is certainly the number one problem. And I'll even say it's not just out the window, it's inside the window. It sensitizes to both UVA and UVB. So even if the windows are up, they still have to cover their skin and wear sunblock. My experience with it has been positive. I've had patients really with multiple relapse or refractory disease enjoy nice responses. It's time-limited therapy. It's fully outpatient. It's appropriate for a variety of healthcare settings. And there is this tail on the curves where you see 20% of patients, give or take, who can have very durable treatment-free remissions. We don't yet have a great biomarker for who those people are, but it is encouraging about the drug's activity.
So, Sonia, us outside of the lymphoma space, we kind of look at your level of excitement to try to figure out what we should get excited about. And I have to say, I hear a lot of excitement about this Lotus 7 study. Again, the same concept we talked about before in ADC and bispecific. In this case, Lonca-T that we just talked about, but now with glofitamab. And pretty interesting. We have safety data, but particularly efficacy data being really exciting. Anything you want to say about that and where you see that heading?
Yeah, so the Lotus 7 trial, is still small numbers. I mean, you see it up here, it's only about 30 patients. But combining loncastuximab-tesirine with the bispecific glofitamab, first of all, looks feasible. Second of all, looks extremely exciting in terms of overall response rate and CR rate in a relapse refractory patient population with diffuse large B-cell lymphoma. The toxicity piece, which is kind of interesting, is that there may actually be a little bit less toxicity when you're using the combination. And I don't know if that's a function of the small numbers or if that's actually a true finding that maybe glofitamab is countering something, with the toxicity. But I think this is another one of those combinations that we want to keep an eye on, going forward.
So, Matt, any thoughts about this? And also this strategy in your mind, is this just adding two different, mechanisms of action, or is there some potential synergy between a bispecific and an ADC?
Well, we see sort of thematically that when you add something good to a bispecific, you tend to increase the activity versus the bispecific alone, and you decrease the rates of cytokine release with step-up dosing, presumably through debulking mechanisms of the good thing you added. So that's thematic and consistent with Juan Pablo's data from this work. Yes, it's only a smaller number of patients treated. This has been expanded. We hope to have 100 patients treated in total, maybe ready for ASH 2026. We'll see, but we're really looking forward to a larger data set, hopefully confirming these very impressive response rates.
So speaking of new things, we have a new bispecific, and actually now we have a bispecific that targets CD19. Before we start talking about the data, we have data both in diffuse large B-cell as well as follicular with this really interesting agent. Can you talk a little bit about this bispecific, what it is, Matt, and what your thoughts are, and also in terms of sequencing, do a CD20 after CD19, or where do you think we might be heading globally?
Really good question. So Survivorship, formerly known as AZD0486, formerly known as TNB0486, is our first CD19-directed bispecific. It's 19 by 3, whereas all of our currently commercially available ones, mosunetuzumab, glofitamab, epcoritamab, odronextamab in Europe, are all CD20 targeting. It's been developed in the trial that you're describing as a single agent multi-histology step-up dosing strategy, similar to what we use with our CD20 bispecifics. And we've seen pretty impressive activity, both in large cell, but in my opinion, even more so in follicular lymphoma. The large cell activity is good in a quite heavily pretreated patient population, including prior CD19 CAR-exposed patients. I will caution that patients had to have proven retention of CD19 expression on their large cell lymphoma before being able to be treated again with a CD19 targeting T-cell engaging treatment like Survivorship. But nice activity, and I would say adequate tolerability, understanding that neither Sonali nor I like the word adequate anymore, right? So we understand that there are clear rates of cytokine release syndrome, and in large cell lymphoma, perhaps higher rates of neurological toxicity, so-called ICANS, than we're accustomed to seeing with our CD20 bispecific antibodies. Small numbers of patients treated, we have to see whether that's a true story. But certainly important to continue to clarify the activity and tolerability of this drug in large cell lymphoma as we go forward.
Sonny, any thoughts on any sort of thoughts about where this might be heading? What you see it as a post-CAR T agent? Also, we'll talk later on about the follicular data that was just presented at EHA. Actually, the slides just came out. We were just looking at it together, and I think it looks like they really didn't see ICANS, at least in that setting. But Sonny, in terms of diffuse large B-cell, any thoughts about where this really interesting bispecific might fit in the future?
Yeah, I think Matt actually hit on a point that I think is important, the CD19 expression. CAR T is an extremely effective option for diffuse large B-cell lymphoma. It's really the standard of care for many patients. And, retaining CD19 expression is important. So I think, where does a CD19 by CD3 bispecific fit? I think there's a couple of possibilities. One, it would be potentially for people where CAR T is not available or not accessible. The other is that if the CD19 expression is retained, it could be used either before or after CAR T. But as you alluded to, the ICANS does give me pause. About 26% of patients had ICANS in this study. 8 of those were grade 3. Luckily, I think we know a lot more about how to manage ICANS and treat it right away. With steroids, we know that tocilizumab is probably less effective for ICANS than it is for CRS. So I think we have a little bit of learning to do with how to use this and see if it's a real signal for DLBCL. We didn't see it in the follicular patient population.
So another new agent, Matt, that you talked about in your presentation. This is a monoclonal antibody to ROR1. Maybe you can explain what that is. But again, everybody's beaten up on This kind of reminds me of chlorambucil and CLL. Everybody, I don't know if anybody's going to ever use R-GemOx again. But any thoughts about this new agent, Matt? What do you know about tolerability issues? Where do you see that heading?
Yeah, I struggle a little bit, I'll admit, with knowing what we're going to do with zilovertamab in the treatment of large cell lymphoma. It does have activity. It's a different target in terms of surface antigen target, but I for a drug that really has the same payload, it's an antibody drug conjugate with also delivering MMAE, just like polatuzumab does. So it's a little bit hard for me to know where this is going, where we already have good MMA delivering mechanisms.
So, Sonny, I know you have a particular interest in upfront therapy of elderly and patients with comorbidities. We've been sort of stuck with our mini CHOP, and most people aren't too excited about that. We have this polar bear study looking at Pola-R mini CHOP. Any thoughts about that? And any thoughts in general about management of the very, very elderly or those with a lot of comorbidities, Sony?
Yeah, I mean, I think this is actually one of the hottest areas within diffuse large B-cell lymphoma right now is this focus on older adults. We know that 25 to 30% of people with diffuse large B-cell lymphoma are over the age of 75. And, there's a big challenge with how to treat patients because overtreatment leads to a lot of toxicity and undertreatment leads to a lot of recurrence. There tends to be a worse prognosis. And so with our mini CHOP, the expected, outcome is about a 49% progression-free survival, which is really no good. So people are trying to build on our mini CHOP, or in this case with polar bear, replace the vincristine with polatuzumab vedotin, similar to the Polarix trial. And so I'm really glad that there's a focus on older adults. So what this particular study, showed is that, one, you could replace the vincristine with the polatuzumab vedotin, and I think the PFS, looks very, very encouraging compared to what you would expect, or what you see with our mini CHOP alone. I think some of the non-chemotherapy approaches that are going on at ASH last year, we had an entire session dedicated to older adults with diffuse large B-cell lymphoma, and we heard a lot about the bispecifics in combination with ADCs or bispecifics being added to chemotherapy. And I think this landscape is going to change dramatically in the next 5 years.
Matt, any clinical pearls to your fellows when they come on July 1st and see a 92-year-old patient presenting with diffuse large B-cell?
The first thing I'll say is that this is still a patient that should be thought about as having curative potential. This antiquated notion that older patients can't receive treatment that offers meaningful benefit is no longer fair. We don't look at people as a number, we look at people as people. And yes, understanding your patient's frailty and their ability to tolerate therapy is important. And dialing up or down the intensity of treatment to match your patient's fitness and comorbidities is key. But age does not keep us from delivering effective treatment.
All right, let's talk a little bit about follicular lymphoma and also mantle cell lymphoma. These were covered by the talk that Sony gave. And maybe we could just start out with a sort of overview slide you began your talk with in terms of some of the, things have changed a lot since all we had was our chemo. Any comments about the sort of spectrum of agents we now have and the ones that we're looking at for the future in FL, Sony?
Yeah, so this is a very exciting area. I mean, we know that follicular lymphoma, even though people can live with it for a long period of time, they get subjected to need for repeated therapy. And so, rather than going back to chemotherapy every time or just rituximab monotherapy, we now know there's a whole number of agents and classes of agents that we can think about. So the ones that I think are super exciting are the bispecific antibodies, as well as new ways of targeting CD19, which, by itself, way back when, targeting CD19 was not very effective. And now we have some antibodies that really have enhanced efficacy. And then finally, with the cell mods, these are very, I don't want to say they're next-gen immunomodulatory agents because I do think they have a slightly different mechanism of action, but they, seem to be independent of many risk factors within lymphoma. And then, of course, BTK inhibitors, which we never really thought had any activity because there were a number of negative trials with ibrutinib. We now see that both zanubrutinib, which is approved for this indication, and acalabrutinib both have efficacy. I think what was really sad this year is that we did see tazemetostat leave the market. This was FDA approved as a monotherapy, but in some randomized trials, and in combination, it appears that there may be a stem cell genotoxic effect with increased secondary malignancies. And so we no longer have tazemetostat in development or available.
So, Matt, we also saw some more data from the R-squared regimen, 5-year survival from the Augment study. Any comments? It looks like R-squared is the backbone for a lot of new regimens that we're going to talk about. But also, we're going to talk about the addition of tafasitamab to R-squared and the InMind study that Laurie Sen originally presented and then published. Any comments on lenalidomide, rituximab, and now with tafasitamab, where that fits into the treatment paradigm right now?
It's interesting, right, where we get these lovely updates from the original Augment investigators, really clarifying the durability of benefit from the R-squared regimen, even as we have all of these novel approaches to adding on to lenalidomide to try to achieve some sort of immunomodulatory synergy, whether it's with monoclonal antibodies like tafasitamab or whether it's with bispecific antibodies like epcoritamab. So lenalidomide continues to be enshrined as an anchor in our treatment of relapsed follicular lymphoma, and how best to leverage it is still a story being told.
Sonali, anything you want to add in terms of InMind? Where does this fit in right now in your own practice?
Yeah, I mean, I think the InMind study was, very impactful from the perspective that it's a time-limited improvement on R-squared, with a PFS benefit, of 22.4 months versus 13.9 months. And in particular, I think in the second-line setting, you get several years of progression-free survival. I think it's also well tolerated. Most people know, how to manage lenalidomide, in this particular setting. And so I think it's a new standard of care for relapsed refractory follicular lymphoma. I don't think it is the standard of care, but it is a new standard. And as we talked about earlier, the CD19 expression was retained after tafasitamab exposure, which I think is important. We don't use CAR T as much in this disease as we do in DLBCL. Whether or not we should, that's another story. But at least it's reassuring to know that CD19 is still there. What's going to change is that we now, coming down the pike, also have EPCO R-squared data, and we have some non-lenalidomide containing regimens. But until then, I think this is a very reasonable option.
Yeah, we did a webinar a couple of months ago, or I don't know why I did this, but I asked ChatGPT, what was the paper of the year in lymphoma? And they popped out with EBCO R-squared. So I guess they kind of picked up the sentiment that a lot of people have that may be the wave of the future. Matt, we were talking before about BTKIs and non-Hodgkin lymphoma in this study, the Rosewood study, looking at obinutuzumab. Just kind of curious right now, is this a regimen you ever use in your patients? And if so, in what situation?
Yeah, I think Sonali hit it when she said that this sort of came as a little bit of a surprise to us, right? Because we'd had a track record of underperformance of BTK monotherapy in the treatment of follicular lymphoma, and mechanistically it didn't even make that much sense that it would work. Here, seeing the addition of obinutuzumab to Zanu, pretty good results. Can't argue with it. How much of the lifting is being done by obinu and how much by Zanu, still not entirely clear to me. And it's hard for me to know exactly where I slot this into my treatment paradigm. I'm certainly very comfortable using it when in patients who have overlap syndromes, where they have CLL plus follicular lymphoma, patients with dual coexisting indolent lymphomas. The BOGO of using a BTK inhibitor in this context to treat both illnesses is very attractive. Outside of that context, I think we have so many other options, it's hard to know exactly when to prefer this approach.
So, Sonali, we talked before about LONCA-T and diffuse large B-cell. What about this phase 2 study with LONCA-T and rituximab and relapse refractory follicular, and anything you want to say in terms of it is an ADC, the target, and the payload here?
Yeah, so this is a single-arm, single-institution trial looking at loncastuximab tesirine plus rituximab, and what there is a stepped up, or at least there is a phased, not stepped up. I apologize. The opposite. It's it starts out with a higher dose and then de-escalates with a time-limited therapy. Although the maintenance does continue for several months, but what they saw, at least in this study, is that the overall response rate amongst these 30 or so patients is pretty impressive. There are still patients who are on study. They saw cytopenias and some generalized edema, but really no grade 4 or 5 toxicities of note. So this may be something that can be built upon or even be a standalone regimen, but of course more data is needed.
So, Matt, your lymphoma colleague, Dr. Matt Lunning, says we shouldn't call this a Lonca-T, we should call this Lonca-T Dex, because he thinks that the Dex is so important. Is that your take also? And how do you approach the use of corticosteroids?
It is. I think that we're still developing a little bit of artistry around Lonca. Somebody makes the point that there's still, in this single-arm phase 2 that Juan Pablo reported out, it was a more extended exposure to Lonca. We've since amended the study a little bit. We're expanding it. We hope to have these data for ASH this year with an even shorter exposure to Lonca, because a lot of the toxicities really are cumulative with this drug. But the fluid accumulation that Sonali referenced earlier with peripheral edema, and even more concerningly, either pleural effusions, pericardial effusions, and ascites, really critical to mitigating those risks is the use of peri-treatment corticosteroids, dexamethasone 4 milligrams the day before, the day of, and the day after treatment. If patients forget their dex, it's okay. They can get their dex in the treatment suite. But if you skip the dex altogether, you will clearly increase the risk of fluid accumulation.
And so also we were talking before about Survivorship, the CD19 bispecific and diffuse large B cell, but also in follicular lymphoma. Here, the phase 1 first in human study. Anything else you want to say about exactly what this is? And also maybe you want to comment on this phase 3 trial up front, Survivorship plus rituximab compared to chemo rituximab, typically BR, a phase 3 study that just today, again, they put out the slides from EHA, mainly safety, but some initial efficacy data looks pretty impressive that we were just looking at. Sonny, what about Survivorship in follicular lymphoma?
Yeah, so this, what was presented previously was the phase 1 data, and the other data is really just hot off the press. But this is an IV bispecific, CD19 by CD3, as we've already talked about. And once you're past the step-up dosing, it's a 28-day cycle, and it is fixed duration in this trial for, at the 2-year mark. Similar to what we had talked about with diffuse large B-cell lymphoma, the incidence of cytokine release syndrome was predictable and manageable. And then what is seen here is that, in this dose-finding aspect, that it seems that anything that was greater than 2.4 milligrams, has activity. And I believe the 7.2 milligrams is the one that's going to go forward. But the efficacy is also, if you look at the progression-free survival, again, for, this initial exploratory study, it looks very encouraging. They have, 18-month follow-up with the 18-month estimate being over 80% in a very heavily pretreated population.
So, Matt, any thoughts about this? I know there's a study in low-volume FL comparing rituximab to mosunetuzumab. That's going to be a really interesting trial. But there's also this phase 3 trial of Survivorship that, again, they just reported some initial, mainly safety, but also some efficacy data. A first-line therapy, a diffuse large G-cell, kind of eliminating chemotherapy. Any thoughts about these strategies of bringing bispecifics up to the first line and this particular agent in terms of what we've seen. It looked like quite a bit of MRD negativity in this initial phase 3 report.
So this is where our field is going, is we're all trying to find ways to move bispecifics into earlier lines of therapy, spare patients the exposure to cytotoxic chemotherapy. Patients don't want it, and increasingly, neither do us doctors. You commented on the important SWOG study looking at low tumor burden patients, comparing rituximab to mosunetuzumab. AstraZeneca is taking a big swing, and we're taking it along with them, trying to move survivorship on the basis of these very impressive relapse data and going right to the first-line setting and comparing this as monotherapy to standard of care cytotoxic chemotherapy. We had the safety run and data reported out, and we actually just received word this week that the FDA has greenlit the American participation in the randomized phase 3 component. So we expect to be seeing study initiation activities over the weeks and months to come, and the study will be open at treating centers, including ours, hopefully, within these next few months. It's ambitious, and it's very exciting.
And you can see again from the study just presented, the phase 3 soundtrack F1 trial. We were talking about ICANS, but here they just had one patient with a grade 1 ICANS, actually very little CRS, at least in this setting. So hopefully it'll be also well tolerated as well as efficacious. So golcadomab, well, you kind of referred a little bit to cell mods, but this is a new generation and beyond, lenalidomide with all its intended problems. Sony, any comments about this? I guess we have two different cell mods for myeloma, mezigdomide and iberdomide. Actually, iberdomide is actually being used in the ongoing first line as maintenance, a Determination 2 trial that Paul Richardson is running. But what about golcadomab, which is also a cell mod agent in follicular lymphoma, Sony? Again, we saw some data on that in the EHA meeting this week.
Yeah, I think that, targeting the ubiquitin proteasome system has turned out to be very fruitful in many lymphomas, but particularly in follicular lymphoma. And, the added advantage of golcadomide is it's really significantly more efficient than, let's say, lenalidomide at targeting the proteins of interest, and particularly transcription factors like Icarus and ALOS, that leads to the desired changes in the microenvironment and within the malignant, follicular lymphoma cell. The nice thing about these agents, they are oral. And we now, the phase 1 actually has been very, it's a lot of patients for what is considered a phase 1 or a phase 1b study. So we've learned a lot about how to use this and, what the toxicities might be. At EHA, I didn't get a chance to see the final presentation, but this has been increased to 60 patients, and in a very heavily pretreated population, there's some really promising efficacy and durable responses. And I think the dose going forward is going to be the 0.4 milligram group.
So we're going to finish out talking about mantle cell lymphoma, and we'll talk about some of the new data that's come out. But also, I want to just take this opportunity to sort of, before we get started on the papers, just to touch base with both of you about how you're thinking through upfront therapy. When I talked to Dr. Michael Wang from MD Anderson, he's all up for getting rid of chemotherapy now completely. Everybody else, they're maybe not quite as ready for that. Matt, of course, we saw the big triangle study a couple of years ago that really put a damper on transplant in these patients. Where are you right now, Matt, before we get into some of these new approaches in terms of upfront treatment in the younger and older patient?
Yeah, I think that many of us are not as confident as Michael that we're already finding ourselves in a post-chemotherapy era for mantle cell lymphoma. But what I would say is that mantle cell lymphoma is not a one-size-fits-all disease, right? There is biological heterogeneity and there is clinical heterogeneity. And understanding patients' age and fitness's impact on treatment choices, as well as on the presence or absence of mutation of TP53, really does bucket patients into different categories that may benefit from different therapeutic strategies, ranging from cytarabine-based chemotherapy incorporating BTK inhibitors like the triangle strategy, or chemo-free strategies like the Boven combination of zanubrutinib, venetoclax, and obinutuzumab for TP53 mutant mantle cell.
And of course, we'll also talk about the fact that now we have just a recently approved new BCL2 agent, sonrotoclax, which of course there are tons of trials with sonrotoclax and CLL that look really interesting. I'm curious to hear where that heads, but that's available now with mantle cell. Sony, again, how are you thinking through upfront therapy of mantle cell? And what are you doing with your P53 patients? Are you still giving them chemo?
Yeah, so absolutely not. I'll answer that first. But I'll just say, we're really, I think, at a sea change for mantle cell lymphoma. It used to be that we would dichotomize patients into older and younger, and the older patients would not get a transplant and the younger patients would. And all we had for the older patients, were things like bendamustine and rituximab. And where we are now, just as Matt alluded to, is that we have a better ability to stratify patients based on some biologic features, including the proliferation rate, the blastoid morphology, and the P53 status. And so the way that we look at it right now is that we're really not offering transplant to many patients. We're not 100% away from chemo, but we're not offering transplant to everybody. And I think either, that involves incorporating a BTK inhibitor up front, which is what's being done in Europe, or using an MRD stratified approach, which was shown by the US intergroup. But to answer your question about P53, we are not using chemotherapy for that group of patients. It is primarily like a Boven or now, with a sonrotoclax-based regimen going forward.
And we'll talk about that. And also, Sony included in her presentation some slides. So there was actually a really great 3-part education. I always love the ASCO education programs every year. So much great stuff. Really great. This is a couple of algorithm slides from Dr. Dreiling, but you ought to check out those presentations. They're very, very helpful. Let's get into some of the new things. Matt, we saw some more follow-up on from the ECHO study, combining a BTK inhibitor, acalabrutinib, with bendamustine rituximab. We saw some data both at ASCO and EHA. Can you comment a little bit about what this study looked at, what they found, and how it's affected the practice in terms of managing upfront mantle cell?
Sure. So ECHO was trying to ask the question of whether adding the BTK inhibitor, acalabrutinib, to the BR backbone up front alters the natural history of this disease versus just leading in with BR, which at the time was a very reasonable standard of care for patients who were older and felt to be unfit for more intensive treatment, which at the time was cytarabine-based chemotherapy with an auto transplant in first remission and then maintenance rituximab. It was positive for its primary endpoint of progression-free survival, adding, 3 drugs versus 2 drugs. That wasn't a shock, I think, for the community. Whether it's really achieved the ambition of trying to alter the natural history of the disease, I think remains a little bit less clear. And while the investigators from ECHO confirmed that you don't need to say BTK for relapse, I'm not personally convinced that you also need to give the BTK up front. And I'm not sure that the triplet versus the doublet is altering the natural history. And this may explain why there's not so much, I think, adoption of this strategy in the first line setting, at least in the United States.
So any thoughts on this? Maybe it's a good question whether you need a BTK up front. I don't say, do we need bendamustine up front? But I guess that's another issue. Any thoughts about some of this data that came out from the trial at ASCO and ECHO here? EHA, here we see the MRD results. Any other comments on this?
Yeah, I think what Matt said is absolutely right. BR with or without acalabrutinib, we see that the triplet is better than the doublet. And I put in one of my slides that it was the author's conclusion that we don't need to necessarily save the BTK inhibitor, that this, by looking at this, time to next treatment to would, help guide some of the treatment selection. And, what they found was that not only was the progression-free survival superior, as was already alluded to, but the need for subsequent anti-cancer therapy was much higher in those patients who received the placebo with the BR. Now, whether or not that actually translates to practice or not, I think is really, up for discussion. I think the toxicity profile was actually better than I thought it might be because, adding on to BR is not easy. Bendamustine is immunosuppressive, it's myelosuppressive. And, when you put in a BTK inhibitor, sometimes you expect to see more toxicity. So I think this is an open question. The MRD results that you're showing here, which is from EHA a year ago, essentially, again, as we've talked about, I think MRD is going to have a very important role as we go forward. And at least here, for those patients who turned MRD negative, could that be used as an opportunity to stop the BTK inhibitor, which in the study, unfortunately, was given indefinitely?
So here's another of the non-chemo regimens, Cala, Ven, and rituximab in upfront treatment. This is a phase 2 study. Sonny, anything you want to say in terms of this strategy? You mentioned the bovine strategy, particularly for these high-risk patients, P53. Any comments?
Yeah, so this triplet approach of a BTK inhibitor, anti-CD20, and BCL2 inhibitor, I think really was pioneered by the Memorial Sloan Kettering Group, where they published their bovine data of zanubrutinib, obinutuzumab, and venetoclax initially in P53 mutated patient population. And I think what we're seeing now are two things. One is that this triplet is being moved into a non-P53 population and focusing on older adults. And the other is that acalabrutinib has been tested replacing the zanubrutinib, and rituximab has been used replacing the obinutuzumab. So I feel like we're entering a myeloma-like world where we have like classes of agents and people are kind of plug and play. But to the credit of the field, I mean, what we're seeing with these triplets is that they are active. We do have to look at cytopenias. But for a population that can't receive, let's say, intensive chemotherapy or have a P53 mutation, this is encouraging activity. They're all phase 2 data. I'll just put that out there.
Matt, again, what about just the BTKI with rituximab? Again, Dr. Wang, if you ask him how does he treat his older patients, this is, last time I talked to him, how he wants to treat most people. And you can understand why, even though this is, only one arm in terms of how effective it is. Again, any thoughts about the non-chemo future of mantle cell?
I mean, we clearly have an increasing sense that BTKs, whether given as a doublet with a monoclonal antibody or as a triplet along with a BCL2 inhibitor, it's not a surprise to any of us that this is an active strategy. For me, what's going to become increasingly difficult is in patient selection and who should be getting a doublet and who should be getting a triplet. And how are we going to be incorporating MRD into determining the treatment duration for these patients? We're a little bit over our skis. We have all these regimens and maybe not such great clarity about how and when to use them best.
So, Sony, what about pirtobrutinib? Of course, there's a lot of excitement about pirtobrutinib. There was just a big paper in the relapse setting at CLL that maybe is going to change practice, adding pirtobrutinib in. Any thoughts about mantle cell? How do you think that through? And a patient who's, let's say, gotten the ECHO regimen or they've gotten BTK and BR, if they're eligible for CAR T, are you already thinking about CAR T with like pirtobrutinib as a bridge, or do you use pirtobrutinib as long as you can? How do you think about relapse mantle cell, Sony?
Yeah. So sorry, I'm just going to respond to one thing Matt said or just add to it, which is that, I don't want to make it sound like chemotherapy is completely going away in this disease. Those people with blastoid morphology or a highly proliferative disease actually will continue. They probably have as good a benefit from chemo as others. So we're still kind of fine tuning it. But the Pirto question is a really good one. This is a non-covalent BTK inhibitor that binds to a different site than the covalent BTK inhibitors, is very well tolerated, like extremely well tolerated, fewer off-target effects. And what we saw, over this past year is that even if patients have received a prior BTK inhibitor that is covalent, there is retained activity. And the way that I'm using it right now, what I have been at least, has been after failure of a covalent BTK inhibitor. But I think given its favorable safety profile, it's going to move earlier and earlier. It seems also able to be combined with chemo and without adding significant toxicity.
So a final comment, we mentioned this new BCL2 inhibitor, sonrotoclax. I know actually they're using it, I think, in a big intergroup first-line trial right now with zanubrutinib. Interesting, even though it's not approved in the CLL, although it is now in mantle cell. We saw at the last ASH meeting some data on this. Matt, any thoughts about this? Also, I've kind of heard that the ramp-up's a little bit easier or shorter with sonrotoclax. Any thoughts about this agent in mantle cell and, for that matter, CLL?
Sure. So Sonro, is of course our second entry into the BCL2 inhibitor space. It clearly has very nice activity and tolerability in both mantle cell and CLL. There are still some residual concerns around class toxicities like tumor lysis syndrome, and step-up dosing does remain an issue. But it was approved for mantle cell lymphoma on the basis of phase 1/2 data. Not a ton of patients leading to that approval, so we're certainly going to want and need confirmatory data to support its ongoing regulatory approval. It's nice to have the agent. It's nice to have more tools for patients. Multiple relapse mantle cell lymphoma remains a very challenging illness to manage, and we're grateful to have additional therapeutic options.
So, Soni and Matt, thank you so much for working with us in this project. Audience, thank you for attending. Be safe, stay well, and have a great night. Thanks so much, Soni. Matt, thank you so much.